Okay, this is a follow-up MRI post-bracing at 12 months demonstrating the normal thickness taut ACL healing outcome. If we look at the ACL on the coronal images, you can follow it from its tibial footprint through to its femoral footprint. The ACL looks to be of uniform signal intensity as well as uniform thickness along its entire length. Then you go through to the sagittal sequences to assess the trajectory of the ACL, and on these sagittal sequences you can see that the ACL again appears to be of uniform signal but also of uniform thickness and is parallel to Blumenstadt's line in a normal taut configuration compatible with the normal thickness taut ACL healing. This is also confirmed on the double oblique sequences where you get a nice view of the ACL from its femoral to tibial insertion point, again demonstrating that the ACL is of uniform thickness and uniform signal intensity along its entire length. So I'm going to go through a case of a normal thickness elongated ACL heel. This is a patient that's at 12 months post CBP. Looking at the coronal images, you get a nice feel for the ACL contiguity from its tibial footprint to the femoral footprint. You can see as I scroll through these images that the ACL looks fairly uniform in not only its signal but also its thickness all the way through, and that the ACL is contiguous. When you come through to the sagittal images, which are more important to assess the trajectory of the ACL, one will notice that this ACL on both the PD FATSAT as well as the PD images appears to have a slight bit of a sag in the ACL. So this would be compatible with a normal thickness ACL heel with elongation. Now the elongation in this case is not extreme, but there are worse cases of elongation that you can see where the ACL would be even further deviated from Blumenstadt's line. So here is an MRI at 12 months post CBP, which shows the healing outcome as reduced thickness of the ACL. However, the ACL remains taut, so we'd call this the reduced thickness taut ACL. If we look at the coronal sequences as a start point, we can check that the ACL is contiguous from its tibial through to its femoral footprint. But as you scroll on the coronal images, the ACL fibers here closer to the tibial end of a greater thickness than the fibers that are closer to the femoral side of the ACL. This can then be confirmed on the sagittal sequences as well as our double oblique sequences. And on the double oblique sequences here, you have the native thickness of the ACL, but as you get closer towards the femoral side of the ACL does appear significantly thinned, and you get that appearance here on the sagittal sequences too, where there is thickening or what's perceived to be normal thickness of the ACL in the lower half of the ACL with thin ACL closer to the femoral footprint of the ACL. The trajectory of the ACL still is taut, which is why it is a reduced thickness taut ACL. This is a 12-month follow-up MRI demonstrating the outcome referred to as a reduced thickness healing with elongation. So in this case, as we scroll from the tibial sided attachment through to the femoral attachment of the ACL, you'll notice that as I'm scrolling here, this is the native thickness of the ACL, and as we get to the initial, what was the initial rupture zone, there is a thinning of the ACL, and then the ACL does start to become more towards its normal thickness, closer to the femoral attachment. The terminology one could use for this is an hourglass appearing ACL heel. You can see on these sagittal sequences that there is a sag within this ACL. It is not taut and parallel to Blumenstadt's line, hence being termed the elongated ACL with reduced thickness. The ACL itself is fairly uniform in its signal intensity from the femoral through to the tibial footprint. This patient happened to have started with a significant displaced ACL with displaced tissue anteriorly and a large gap between the two ends of the ACL, hence resulting in a reduced thickness, elongated hourglass appearing ACL heel. This is a 12-month follow-up MRI showing the healing outcome as being a fork tongue outcome. The terminology of a fork tongue outcome reflects the insertion at the femoral side of the ACL, not only extending to the native footprint of the ACL at the femoral attachment, but also attaching onto the lateral wall of the notch, slightly short of the native femoral footprint of the ACL. So in this case, as we follow the ACL on the coronal images, you can see the ACL here clearly contiguous. It's of uniform low signal intensity, and here's an attachment point onto the lateral wall of the notch. And you continue to follow this with a thinner segment of the ACL extending to the native femoral footprint of the ACL. This can also be shown on the sagittal sequences as this here being the lateral sided fibers of the ACL latching onto the lateral wall of the notch. And as I scroll one slice over, you can see the fibers also extending to the native femoral footprint of the ACL. This higher signal in the middle reflects the gap between the two attachments of the ACL onto the femur. This finding is also demonstrated here on the double oblique sequences, with this being the lateral wall attachment and this being the femoral footprint attachment. So the fork tongue outcomes are typically associated with ACL injuries that have a greater degree of tissue displacement outside of the notch at the initial start point, or larger gap distances between the two ends of the ACL. This is a follow-up MRI post-bracing demonstrating a non-healing ACL. So as I scroll on the coronal images, here's the ACL at its tibial footprint. As you scroll further back, you can still see some displaced tissue beneath the lateral femoral condyle. And as you scroll further posteriorly, you can see that the ACL becomes non-contiguous with an empty notch sign, and there are no fibers visible literally all the way out to the femoral footprint of the ACL. This finding can be confirmed on the sagittal sequences as well, where you see the ACL in its inferior 2/3 but no ACL tissue in its proximal 1/3, and the double oblique sequences also show the exact same outcome. So this is what one would classify as a non-healing ACL.